All right, class. So we start chapter 4, which is the shoulder girdle. Um, so the entire upper extremity depends upon the shoulder girdle to serve as a base from which it's function. So this is interesting. The only attachment, your entire upper extremity to the axial skeleton is via the scapula and its attachment through the clavicle at the sternoclavicular joint. So this is why we emphasize so much on scapular stability, rotator cuff strength, because really you can have a lot of issues if you don't have scapular stabilization and rotator cuff strength, because the only attachment is of the upper extremity to the axial skeleton is via the scapula and its attachment. So it really relies on the muscles and ligaments and tendons to hold it in place. Especially if you're an overhead athlete, you really rely on scapular strength to hold you in place. If you don't have good scapular strength, you can run into a host of problems. And anyone that's a pitcher or overhead athlete, you guys know that you've had some kind of shoulder issue in your career. And a lot of times it comes down to scapular stability. Now, so the bones that are related to this, there's the scapula itself, which is this, and the clavicle. So there's the clavicle. Okay, so it moves as a unit. The clavicle's articulation with sternum is only bony link to the axial skeleton. It's amazing, right? So this little bony link right here is the only attachment to the axial skeleton. So the anterior sternoclavicular ligament, the corticoclavicular ligaments, the superior AC ligament. You've heard of AC joint separations, right? It happens in football a lot. So really, these ligaments play a key role, but this is just static. We want dynamic stability with the muscles, right? So ligaments provide static stability, but the muscles will provide dynamic stability. Some key landmarks that we have, the manubrium, which is right here, the clavicle itself. We have the coracoid process right here, the acromion process right there, the glenoid fossa. This is where the head of the humerus articulates. We have the lateral border, which is your armpit, axillary border, inferior angle, and the medial border right here. So make sure you know these bony landmarks and what bone they're associated with for the next exam or quiz. Look at that. What do you think's fractured right there? That's the distal end of the clavicle. Okay, football injury. Now, if you look at the posterior view, you've got the spine of the scapula. So the supraspinatus, which is one of the rotator cuff muscles, sits in there. You have the infraspinatus that sits here, and then the teres minor that's in there. So again, looking at different views and being able to recognize this. Again, this is not an anatomy class, so all of this should be just review. I'm not going to go over what each part of the bones are because you should have had that class already. And even scapulas break. So if you look at that, this is a snowboarding injury. So if you see that fracture right in there, so that's pretty traumatic. When scapulas break, you had a pretty gnarly fall right there. There is the clavicle right there. You have the sternal end that attaches, and then the acromial end that attaches. So this goes to the sternum, and this goes to the scapula. So this would be a left clavicle because it goes anterior, then posterior. If you look at on a regular human right here versus a skeleton, you got the traps, you got the AC joint right there, you'll see the delts right there, and here's the clavicle, and here's your pectoralis major. From the back, you see the spine of the scapula, again traps, AC joint, delts, and there's the inferior angle of the scapula. So joint motion occurs at the sternoclavicular joint, to a much lesser amount at the AC joint. So really, you have more motion here than here. If you try to get too much motion here, you get a separation. So the sternoclavicular joint, classified as multi-axial arthrodial joint, also classified as a sellar joint. Movements in relation to the manubrium, the clavicle moves, and these are great quiz questions, anteriorly 15 degrees with protraction, posteriorly 15 degrees with retraction. some slight rotary gliding movements. Remember, this is a movement anatomy class, so what we look at the degrees, the movements in relationship. So this is where the nitty-gritty comes. This is different from anatomy. In that anatomy, we just memorize what a scapula is. Here we look at, well, okay, now we know the joints already. Well, what is the relationship? And why is this important? Well, if your sternoclavicular joint doesn't move 15 degrees, doesn't move posteriorly 15 degrees, well, you have to compensate somewhere. And where are you going to compensate? You can compensate at the glenohumeral joint, you can compensate at the elbow, you can compensate at the neck. That's what we look at. And from an overhead athlete standpoint, this is something that we want to look at and see if they have that. Ligamentous support, it's anteriorly by the anterior SC ligament, posteriorly by the posterior SC ligament. Costoclavicular and interclavicular ligaments provide stability against superior displacement. Okay, so we really want to pay attention because you've heard of clavicle dislocations. Well, it's usually because these ligaments aren't unfortunately able to do their job, or the force was so great that it caused the clavicle to dislocate or fracture. Now the AC joint, again, you've heard of AC joint separations, arthrodial classification. It has 20 to 30 degrees of total gliding and rotational motion accompanying other shoulder girdle and shoulder joint motions. So it's supported by the corticoclavicular ligaments, the conoid and trapezoid, superior AC or acromioclavicular ligament, and the inferior acromioclavicular ligament. Unfortunately, is often injured in sports, especially football, rugby, anything that's contact. Okay. The scapulothoracic, which is your scapula on your thoracic cage, not a true joint, does not have regular synovial features. Movement depends on the SC and AC joints, which allows the scapula to move. Now this is very, very important right here. It allows 25 degrees of abduction and adduction, 60 degrees of upward and downward rotation. So really your glenohumeral joint only moves 120 degrees, and then the rest comes from your scapulothoracic, which is the 60 degrees. So 120 plus 60 gives you 180 degrees. Most people lack the scapulothoracic range of motion in overhead athletes or reaching overhead, and that's what causes the limitations in their shoulder. And what happens is if they don't have it, they jam it up in there and they cause impingement and rotator cuff injuries. So don't neglect the scapulothoracic joint. This is one of the things that I treat a lot in the clinic, and trying to get the scapulothoracic joint stable. But first we got to get it moving. If it doesn't move 60 degrees, what's causing it? And then it causes 55 degrees of elevation and depression. So these numbers, when you're studying, these are key. These are great quiz questions. Supported dynamically by its muscles and no ligamentous support. So there's no ligaments on the scapulothoracic joint. It's all muscle. Focus on specific bony landmarks, inferior angle, glenoid fossa, acromion process. All movements have a common pivot joint point at the SC joint. So this is the pivot right here. Okay. Shoulder girdle movements is equal to scapular movements. Wherever the scapula goes, the clavicle follows. So the scapula goes up, clavicle goes up. Scapula goes down, clavicle goes down. Scapula goes retraction, then clavicle goes into retraction. So here are the movements. If you look at abduction, that's abduction of the scapula. Adduction is retraction. Okay, so retraction, protraction. You're mostly in this state right here where you have rounded shoulders and forward shoulders. This is no good. We want you to do retraction, try to get your shoulders back. Upward rotation and downward rotation. So if you look at the scapula, see how it's coming into downward rotation here, which is good. Most people lack upward rotation. So if you lack upward rotation of that scapula, you see, then, and if you look at this, she actually has some weakness in her, see how it wings out? She actually has some weakness in her serratus anterior, and I'll show you that little winging right there. So they should have picked a better model than that, but oh well, maybe that's why they picked it, so we can see that. But she has definitely some weakness where it wings out right there, bam. See that? And then it goes up. So that would be of concern to me if she's an overhead athlete. Boom, see, it doesn't stabilize right there. So being able to pick that up, even when she comes back down, watch how that scapula comes, and then bam, it wings out a little bit. That's not normal. We want that scapula to stay on top of that. So it definitely shows some weakness right there in here, serratus anterior. Here's depression. So we want to work on depression right there. Depression would be lower trap, and then elevation would be upper trap, shrugging the shoulders there. Okay, so you want to work on depression more than elevation. What are the shoulder girdle muscles? Well, they stabilize the scapula so that the shoulder joint muscles will have a stable base from which to exert force for moving the humerus. They contract to maintain the scapula in a relatively static position during the shoulder joint actions. They contract to move the shoulder girdle and to enhance movement of the upper extremity when shoulders go through extreme ranges of motion. So the shoulder girdle muscles are very important. For some shoulder girdle movements, the scapula must rotate or tilt on its axis. So it can do a lateral tilt, which is an outward tilt during abduction. Scapula rotates about its vertical axis, resulting in posterior movement of the medial border and anterior movement of the lateral border. Medial tilt, inward tilt, return from lateral tilt during extreme adduction. So scapula rotates from its vertical axis, resulting in anterior movement of the medial border and posterior movement of the lateral border. So these little tilts are important. Some people have extreme tilts, and that's what causes issues. And I'll show you some examples of this so you understand what these tilts mean. You have an anterior tilt, rotational movement of the scapula about a frontal axis occurring during glenohumeral hyperextension. Superior border moving anto-inferiorly and inferior angle moving posterior superiorly, so it kind of pops up. And a posterior tilt, downward tilt, rotational movement of the scapula about the frontal axis during glenohumeral hyperflexion. Superior border moving posterior inferiorly and inferior angle moving anterior superiorly. So again, knowing these tilts, and the reason that these tilts are important is that when there's a dysfunction, something's not going on correctly. So that's where we would have to address it with maybe some manual therapy, maybe some soft tissue, or then re-emphasizing it with some exercises. So the shoulder joint and shoulder girdle work together in carrying out all upper extremity activities. Shoulder girdle movements is not dependent on the shoulder joint and its muscles. So they work together, but they're not dependent on each other. And it's very important. So as the shoulder joint goes through more extreme ranges of motion, the scapular muscles contract to move the shoulder girdle so that its glenoid fossa will be in a more appropriate position from which the humerus can move. And this is the key. This is a great point right here. If your scapula is not in the ideal position, then your humerus, which is your shoulder joint that you call, will not be in the ideal position. And that's what can cause impingement in your rotator cuff. Without the accompanying scapular movement, the humerus can only be raised into approximately 90 degrees of total shoulder abduction and flexion. And if you try to push past that, that's where you get impingement. This works through the action of appropriate muscles of joints working in synergy to accomplish the desired action of the entire upper extremity. Example. If you want to raise our hand out to the side laterally as high as possible, the serratus anterior and trapezius, middle and lower fibers muscles upwardly rotate the scapula as the supraspinatus and deltoid initiate glenohumeral abduction. You're like, whoa, yes, serratus, trap, middle, and lower trap all have to work to rotate the scapula and fixate. So if you have weakness in any one of these areas, you're going to get an overpowerment of either the delts or the trap, upper trap, and you'll cause that scapula to rotate undesirably, and you might cause impingement. Synergy between the scapula and shoulder joint muscles enhances movement of the entire extremity.